Nigel. I've been a GP for 28 years. I've loved almost every minute of it, and I'm very pleased to be here this morning to talk to you about general practice. I've been asked to give a very general introduction about general practice, what it is, what we do, why we do it, how we do it. And so hang on to your hats because it's going to be quite a fast ride. Okay, so we start with some facts. There are around 60,000 GPs in the UK. That's almost half the total number of doctors. There's around 10,000 practices. Each GP has almost 2,000 patients registered with him or her, and the majority, but the overwhelming majority of the population is registered with a GP. We do 370 million consultations per year. That's more than 1 million consultations every day if you cut out the weekends. We handle some 90% of all health contacts with the NHS, and we refer about 5% of our patients. So whatever your perspective in hospital, remember there's another 19 that haven't been referred. What do we do? Well, we are expert generalists. Generalism, we're able to use a different way of looking at the whole patient. We look at people who come with early presentations of disease, don't fit into a nice, neat model of having all the particular symptoms of a particular disease or a particular syndrome. So we're expert at looking at the generality of patients' complaints and at early presentations. And we don't really call specialists partialists, but often it sounds like it because they only look at one part of the body. We use a biopsychosocial model to assess our patients. With biomedicine obviously is core, that's what you spend most of your time in medical school learning, but also we have to take into account the psychological aspects and the social aspects of a person's presentation, because patients come to us with illnesses, they don't come to us with diseases. We look at them from the point of view of, does this patient have a particular disease? But actually patients have illnesses and doctors have diseases. So we use a holistic model to try and focus down what exactly is the issue that this person is presenting with. We look after whole families. Many of you, when you get into practice, will see that we know all the members of the family, and we look after people over a long period of time, so-called cradle to grave. And we use our eyes, our ears, our hands, our heads, and our hearts. And probably most importantly there is our hearts, because that's about engaging with the person rather than just dealing with the disease. So we're general physicians. We work like the hospital physicians of about 10 years ago now in terms of complexity and long-term conditions. So we work as general physicians, gatekeepers, and there's an article, BMJ article I've just passed around which you might be interested in. It's an old paper now, but it's still true, and it's regularly voted the best general practice paper of the last 30 years and regularly reproduced, so you may or may not find it of interest. We also act as patient advocates, and we also coordinate the care of people. So some figures: 1 year of care by your GP costs 10% of 1 day in hospital. It's actually cheaper to get comprehensive care from a GP than it is to insure your hamster for a year. There are more GPs per head of population. You have a lower all-cause mortality, and an increase of 1 GP per 10,000 population is associated with a 6% decrease in mortality. And as I said earlier, 90% of all patient contacts with the NHS are with GPs, and we hold 8% of the total budget. So, don't diss the NHS. This is the message from this slide. This is an independent international evaluation of the performance of the NHS compared with the performance of the health systems in other parts of the world. You see, comparing Australia, Canada, France, Germany, Netherlands, New Zealand, Norway, Sweden, Switzerland, UK, and the US. And looking at the overall ranking, you will see that the UK comes #1 in terms of these factors in the left-hand column. So, UK is #1 in terms of effective care, safe care, coordinated care, patient-centred care, cost-related, access, and looking particularly at a cost-related issue, And the only one we come down on is the timeliness of care. So that, of course, is to do with waiting lists and so on. But you'll see on the international comparisons, this is an American Commonwealth study, you'll see we're also the cheapest. That's how much, the bottom line is how much we spend per head on patients. So the NHS delivers a fantastic performance at a very cheap price. But things are changing, and looking at you all now and thinking about your next 30 years careers as doctors, there's 3 challenges which you're going to have to face. Now, we have started to address these issues with my generation, but I'm coming to the end of my time as a clinical GP. The challenges I'm going to identify for you are 3. One is the increase in long-term conditions and multimorbidity. By 2020, there will be 1 million more people over 65 than there are today. It's a huge issue because the longer you live, the more long-term conditions you get, and the more of them you get. So there's going to be increasing demand on the whole system. Whether you work in hospitals, whether you work in general practices, there is going to be increasing demand on you as clinicians. And thirdly, our patients want better partnerships with us. So I'm going to take each of these challenges in turn and suggest some of the ways we might address them. So I think we need to think about health differently. We're going to talk about that in a moment. I think we need to think about the way we do medicine. I think that we cannot continue with the old model of just trying to deal with an isolated biomedical condition. And I think we have to change our partnerships with our patients if we are to address the challenges. So, challenge 1, increase in long-term conditions and multimorbidity. Now, many of you will already know this, but a long-term condition is any medical condition that cannot currently be cured, but can be managed with the use of medication and or other therapies. Now, over 15 million people in England alone have long-term conditions. 50% of people aged 50 have a long-term condition, and 80% of people over 65 have more than one long-term condition. And this is 30% of the population, but we spend 70% of our NHS resources on people with long-term conditions and multimorbidity. And it's at least half, if not more, of all our GP appointments. Why does it matter? Well, I'm coming to that in just a moment, but I just wanted to show you this slide, that the longer you live, the more long-term conditions you develop. So if you look at the horizontal axis, we've got the age group, the older you get, and the right-hand axis, the number of conditions. You'll see that some people between 80 and 85 have more than 8 long-term conditions, but virtually everybody, 90% plus, have at least 80% plus have at least one long-term condition. So the older you get, the more conditions you get. Why does it matter? Well, it matters because if you've got one long-term condition, you're very likely to have another long-term condition. Now this is a rather complicated slide, but I just wanted to show that if you look at the vertical column here, these are the percentage of patients with this condition. So you've got coronary artery disease, you've got hypertension, heart failure. And then if you look across the top there, these are the people who also have another condition. So if we look at that first bubble, that first blue bubble, those patients with coronary heart disease, 52% have hypertension. So what, okay? You're not surprised at that. But if you go along, you can see that 72% of people with coronary heart disease also have other conditions. Now, why is this important? Because our health system is set up to see people as if they only have one condition. And the majority of people who we see in hospital or in practice do not have only one condition. So the commonest long-term condition is multiple long-term conditions. And if we look at admission rates, then we look at the red line, you can see that the red line, the top one, the graph, represents the numbers of emergency admissions. And as you all know from all the press and the news, that the number of emergency admissions is going up exponentially. And then if you look at the number of conditions along the bottom there, you can see the more conditions you have, the more likely you are to be admitted to hospital in an emergency. And the blue line are the numbers of patients whom you could possibly prevent their admission by getting sorted in the community and being proactive around care planning and so on. So let's just think about health for a minute then. Health, this is the definition that's been used since 1948, and this is what all health systems, all doctors, nurses, midwives, whatever, have been trying to achieve. That is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And that is the underlying assumption, very often, of the way that our health services are organised. Well, actually, I hope you can see from the fact that we're getting older, and we're getting more conditions, we're getting more than one condition, the idea that we could achieve health using this definition, I think, is not possible. So, I'm going to give you a new definition of health. A new definition of health is the ability to adapt and to self-manage. Because if increasing numbers of our patients have multiple conditions, which are long-term conditions, then we're not in the business of curing anymore. We're in the business of supporting people to adapt and to self-manage their own conditions. Challenge 2, increasing demand. This is just for GPs. There's similar figures for hospitals. There's been a 75% increase in consultations in the last, since 1995. It's actually gone up a lot more. Recently, we've had an additional 45 million consultations per year in general practice in the last 3 years. The average number of consultations increased. We see people because they're sicker, and they're sicker for longer, and they have more complex problems. We have more consultations per year, from around 4 to around 6. We've increased the length of consultations, and we're seeing people more than 70. We're seeing them more than 1 a month. So there's been a huge rise in complexity and multimorbidity. So here are our greatest resource. We sometimes forget this. Our greatest resource in dealing with this huge demand and increasing multimorbidity, increasing long-term conditions, are our patients themselves. And it's true, our patients do want better partnerships. The NHS patient surveys have been absolutely consistent for the last 15 years. Half of patients want more involvement in their treatment and management decisions, and that translates into 1 in 3 of our patients in general practice and 1 in 2 of our patients in hospital want more involvement. So how can we develop better partnerships with our patients? How can we start to deal with this demand, the change in the nature of disease that come to us, the new definitions of health that we need to use? Well, there's 3 areas which have been suggested as part of the answer, though clearly not all the answer. There needs to be more resource put into the health service, but there's care planning, there's what's called support for self-management, and there's shared decision-making. Let's talk about care planning. Now, sometimes when we're acting as students or doctors with our patients, people with long-term conditions, we think that we're working in isolation. It's just actually what's important is what goes on in that interaction between us and the patients. But actually, this slide, called the House of Care, which you'll see quite a lot of in the next year or so, this House of Care explains that we are part of a system, and unless you've got all the other bits in place, then it's very hard to deliver the sort of care and the quality of medicine that we all want to deliver. So at the heart of it is the consultation. That's person-centred coordinated care and support planning. That's proactive, it's thinking about those admissions. If you go through people's notes, there are lots of risk scores you can use which work out how likely it is they are going to be admitted to hospital in the next 6 months or the next year. So the idea is that you would look through at your risk patient. It's about 2% of the practice population who are at risk of being admitted in the next year, and put in place support services to try and reduce that unnecessary emergency admission. That's at the heart of it, but it only works, this sort of proactive care planning, if you've got doctors, health professionals, nurses who are committed to working in partnership with their patients, to actually sharing decisions, sharing management plans. It only works if you've got patients who are willing to engage and take responsibility for their health. It only works if you've got the money for it, if you've got commissioning, if the services are commissioned that allow you to deliver this type of medicine. And last of all, the roof, you have to be pretty well organised to deliver this sort of care. But this is the future of care. It's not about curing, it's about getting organised. It's still essential, that interaction between the doctor and the patient or the person with a long-term condition. But without all this around it, then it's very hard for you to deliver this sort of care. So the second, that's care and support planning. Now let's think about support for self-management. How do we actually help people look after themselves? Well, this is from a World Cafe event that we did, and this is called the green wavy line slide. Again, you may well see this in the next few years. The green wavy line is what one of our patients with a long-term condition said. This is what my life is like. It's like a green wavy line. That is the person living their life with a long-term condition. And then the orange bars are when I see the doctor or when I see the nurse. Which means that if I'm lucky, I will see a doctor or a nurse for about 2 hours per year. Whereas I've got 8,760 hours to live on my own with this long-term condition. So I would say here that day-to-day management of a person with diabetes, chronic obstructive pulmonary disease, coronary heart disease, day-to-day management of that is self-management. But patients have to be ready to take up the responsibility for their health. And so we have to support them and empower them to do this. And classically, you don't have to know too much detail about this, but classically we talk about activating our patients. We've got level 1 where people are prepared to start taking a role in managing their own condition. And diabetes is the classic example. I mean, diabetes is a disease that has to be managed by the person themselves. You cannot manage it for them. They have to be able to do that. So for people with diabetes, then they tend to be moving on to building knowledge and confidence at level 2. And then level 3, adjusting their own insulin dose, adjusting their own diet and exercise. And level 4 is being able to maintain their behaviours. Now sadly, at least 75% of the people in England are still at level 1. We've only got about 10 or 15% at level 2, very few at level 3, and hardly anyone at level 4. And those who are at level 4 tend to be those patients with, for example, diabetes who've been managing their own condition for a long time. So one of our jobs as a doctor, I think, is to activate and support our patients to take more responsibility for their own health. And then shared decision making, that's the third element that I want to talk about. Now, the shared decision making is supposed to be the holy grail of healthcare, that we share decisions. And for all of these outcomes here, better consultations, better risk communication, better health literacy, better decisions, fewer unwanted treatments, better lifestyles, etc. There's good evidence for all of those. And yet here we have a very excellent evidence-based intervention that very few of us use. And I think if we're going to meet some of these challenges of older people with multiple conditions, long-term conditions, we need to ask ourselves, why do we not put the evidence into practice that shared decision-making works and makes a huge difference, not only to you for your satisfaction of your job, but also for your patients too. And there's just a very quick, some research we published recently using patient decision aid, and we invited people with diabetes to make decisions about their own care. And that decision was whether or not to go onto insulin. And everyone thought, oh, you can't do that, it has to be the doctor's decision. But in fact, we did a proper randomized control trial and showed that the care of the people who chose when they started insulin actually improved compared to those who went through the normal medical management, whereas the doctor who decides whether or not the patient goes on to insulin. You can read that if you're interested. So in summary then, of this part anyway, GPs make the NHS safe, fair, accessible, and value for money. Now, Kirsty asked me if I'd just tell you a little bit about my career. I've had a really interesting and varied career. I started life and trained as a neonatal paediatrician, loved it, did my MD in neonatal paediatrics, but actually got a little bit bored with it after a while because you get very good at it, but you're doing the same thing over and over and over and over and over and over again. years and years and years. And I couldn't imagine myself older doing the same thing for the next 25 years. So I took the plunge, I saw the light, I went into general practice, and I have to say I never regretted a moment of that decision, because it's given me so many different opportunities. And I've listed some of them here. I mean, with the first opportunities, I was able to set up my own practice and practice medicine in the way that I thought it should be practiced. And we built up this practice. It was a small, single-handed practice, and in a very tough part of Sheffield, so I was able to address some of my social conscience worries about healthcare and health inequalities, and developed it into a four-handed practice, which is now a teaching practice. I was able to develop my teaching interests and did a diploma in teaching undergraduates and postgraduates. I did my PhD while I was in practice on heart-sink patients. You would hear all about heart-sink patients during your career. I would say the message to take home is that heart-sink patients are in your head. They're not actually objective and out there. And I've been very lucky to find a nice niche, really. I've got a niche of clinical practice combined with some teaching and combined with some high-quality research, and working with members of the primary healthcare team. And I also now work 2 days a week in London for the Royal College of GPs. So I think it's a really great life. I have a contract that's 50% academic, 50% clinical. So you keep your street cred, you get to do the clinical stuff that you like, but you also do your 50% academic, which stretches you into lecturing. So I said at the beginning that I don't regret a minute of it. I think that's true, and I think it's very nice at the end of your career to be able to say, well, actually, that was the right thing to do, and I've loved every minute of it. So thank you all very much for your attention.